Welcome back to Clinical History in English. This week's case is a patient with a rash. You're working in a primary care medical centre and a 76-year-old male with a rash comes to see you. You take a history from the patient and you record the following. So the presenting complaint is a rash. The history of the presenting complaint. Over the past 2 weeks, he has noticed a rash. It started as a red patch and then develops into a large blister. The blister doesn't burst easily. The fluid is clear, very occasionally with a little blood. When the blisters burst, the skin is sore and sensitive. The blisters are located on both his legs. Right, let's continue with the presenting complaint. Prior to the appearance of this rash, he has complained of generalized itching or pruritus. He describes feeling generally well. He denies fever, malaise, or fatigue. He denies oral lesions. In terms of his past medical history, he has hypothyroidism, essential hypertension, and hypercholesterolemia or high cholesterol. In terms of his family history, his father had raised blood pressure and prostate cancer and died at the age of 92 from an MI or myocardial infarction. His mother had raised blood pressure or hypertension and dementia. She died aged 88 from a chest infection. His sister is aged 72 and is fit and well. Fit and well is a phrase we use often in medical records in English, and it's just a ready-made phrase that we use to say the patient has no significant illnesses or diseases, fit and well. So in terms of drug history, there are no known drug allergies. He takes amlodipine 5 milligrams once daily. He takes simvastatin 20 milligrams one at night time. And he takes levothyroxine 100 micrograms once daily. Now these ODs and ONs are actually the initials from the Latin, but as you can see in this case, OD you can think of as once daily, and that helps you remember the letters, and ON helps you remember once at night, so you don't have to worry too much about the Latin for those particular ones. For things like BD, TDS and QDS, that's a bit more complicated. Right, let's continue. So in terms of the social history, he's a retired primary school teacher. He's independent in all his ADLs. Now, if you've seen a few of the videos before, hopefully you will remember ADL stands for Activities of Daily Living. He lives with his wife. He's a non-smoker. No alcohol, which we sometimes abbreviate in English as to OH, and no recreational drug use. So what are our differential diagnoses? What could this be? So there's a few possibilities. This could be perhaps bullous pemphigoid. He's in the right kind of age group for it. It could be dermatitis herpetiformis, so a sort of skin variation of celiac disease. He's got hypothyroidism, so he's got another autoimmune disease that could fit with them. He's taking a few medications, so this could be a bullous drug reaction, although from the history it doesn't sound like he's on any medication that's been started recently. And leg edema can cause blisters, and leg edema is common in older patients, so that's another possibility. So on examination, in terms of inspection, he appears well. There are several crops or areas or groups of large, tense, fluid-filled blisters on both lower extremities. Now, to talk about the legs, and in medicine we often call them either the lower extremities or the lower limbs. The underlying skin, the skin underneath the lesion, is erythematous. Erythematous just means red. There are several areas of hyperpigmentation. Now in English, the words hypo and hyper, if we say it quickly, they sound very similar. Hyperpigmentation, which did I say? More or less. So we often, when we speak to colleagues, we exaggerate the pronunciation so that it's very clear what we're saying. So I would say hyperpigmentation. In normal speech, you can just say hyperpigmentation, but then it becomes a little confusing. So hyperpigmentation from old blisters. So where he's had previous blisters, the skin afterwards is, and there's an increased coloration of the skin. From old blisters that had burst and healed. There is no lower limb edema. So that makes our last differential diagnosis almost 100% not the right diagnosis. So we've ruled out leg edema as a cause. Here's an image of what we might be seeing with a patient like this. I've copied this image from a website called Primary Care Dermatology Society UK. I have found this website so useful in dermatology patients. It has different areas where they classify it according to the site of the lesion or according to the type of the lesion, for example, blistering lesions. And it's got great pictures, it's got really good summaries of the clinical conditions. So I really recommend that as a helpful resource. I use it all the time. So this is the kind of picture we're looking at. So you can see there's large blisters. In fact, they're so big, it looks like what we might call a bulle. So let's look at our management. What you're going to do as a primary care physician seeing this patient. So we decide to make an urgent referral to dermatology. And in the meantime, we can send him for some blood tests, including skin antibodies and inflammatory markers, because we're thinking maybe, what are we thinking? Well, let's see. The dermatologist performs a skin biopsy, which confirms a diagnosis of bullous pemphigoid. They start him on steroid treatment. So for an example of that could be prednisolone, 20 milligrams once daily, and also add a proton pump inhibitor or PPI. So for example, omeprazole or lansoprazole for gastric protection. Okay, so that was a simple case, but let's have a little look at some useful words in dermatology. So we mentioned the word crop. So a crop is a group of discrete lesions in close proximity. So it's a group of lesions, but they're separate lesions. So this photo is an example of 3 different crops. A plaque. We often use the word plaque when we're talking about psoriasis. So you might say a psoriatic plaque. A plaque is a large raised area or a large area that's palpable. So it might not actually be raised, but you can feel it and it's one discrete area. Then we have the word scaly. That's another very useful word. So scales are what you have on a fish, and the skin can appear like that when it's dry and it's flaking when it's falling off. So scale, another useful word. So a typical description of psoriasis would be to say that it's a red or erythematous plaque with a scale on top. Erythematous, the word I just said, is a fancy way of saying red. So you can just simply say red, but it sounds, I guess, extra cool to say erythematous. And then we mentioned in this case hyperpigmentation. So that's an area of darker coloured skin, which is often what you see post-inflammation. You can also see the opposite, which would be hypopigmentation. Okay, so lighter coloured skin in an area. 2 other very helpful descriptive words in dermatology. A macule. A macule is a flat lesion which will have a colour, whether it's brown or red or whatever. A papule, similar to macule, it might have a colour, although it might not, and it just means that it's raised, so you can feel it like a bump on the skin. So a typical rash when a child has a viral illness might be what we call a macular-papular rash, meaning it's got both flat lesions and raised lesions. Typically they're red in a viral exanthem. And then let's look at blisters. So we can split blisters according to their size. So vesicles are the small ones, a small fluid-filled lesion. Usually thinking of a clear fluid. If it was sort of more green in colour, you'd be calling that a pustule. So a vesicle would be the typical lesions that you see, for example, in herpes, where you have crops of lots of little blisters. And then a bulla, 1 bulla, 2, 3 or more bullae with AE at the end. That would be a large fluid lesion. So for example, in the case we've seen today of pemphigoid. So let's just review some of the words that I think are useful or difficult that we've looked at in this case. So we have the word rash. Rash refers to any skin eruption. So typically something that comes and goes or changes with time. A blister, so a fluid-filled lesion, is not telling us the size. So it's a kind of word a patient would use. A patient will not say a vesicle or a bulla. They will say blister, regardless of the size. Dementia. This patient's, one of their parents, I forget if it was the mother or father, had dementia. I think that's an important word because obviously it's spelt dementia, but we say dementia in English with a sh at the end. And then we have the word burst. So when the blister burst, when it broke and the contents came out. And then we have the word itch. That's a word patients will say to you a lot, won't they? I have an itch. So in the terms of a noun, or it itches. My skin itches in terms of a verb. Then as an adjective, itchy. My skin is itchy would be the adjective. Pruritus, which is the medical way of saying itch, so pruritus. Malaise was a word I put in. Doctors use this frequently. I think it comes from the French, and mal meaning bad. So it's just that feeling of just not feeling good, maybe tired. A phrase we like a lot in English is under the weather, which is just a non-specific way of saying feeling unwell. So malaise is another way of saying that. Typically we think of low energy with malaise. And then edema. In UK English, we will spell that O-E. In US English, they would just put the E without the O. But it's pronounced edema. And to finish off, let's look at some of the abbreviations that we covered in this week's case. BP. Let's see if you can remember what that one was. What's BP? Blood pressure. MI, myocardial infarction. OD, from the Latin, but in English it would mean once daily. ON, also from the Latin, but we're talking about once at night time, so one tablet at night. ADLs, the patient was independent in all his activities of daily living. OH, I think many countries we all use this to abbreviate alcohol because of the chemical formula. And PPI, proton pump inhibitor, like omeprazole or lansoprazole. So I hope that case has been helpful with some new vocabulary and just good to practice your listening in a medical context. If you like the video, please give us a like or a comment because it helps YouTube to bring these videos to other people's attention. And feel free to join us as well at Clinical History on Facebook and Instagram. Hope you have a great day. Take care.